Hi, welcome everybody. We will give 1 minute for everyone to join. So thank you for your patience. Okay, good afternoon, good morning, and good evening to everyone. We welcome you all, particularly those of you joining from far away or at late or early times. Thank you for joining this WHO EPI-WIN webinar on WHO MERS-CoV investigation protocols. For those new to EPI-WIN, this is the WHO Information Network for Epidemics for Science and Knowledge Translation in Health Emergencies. Our goal is to translate science in accessible, understandable, and relevant ways for evidence-informed actions and decisions in health emergency preparedness and response. Today, we have a great panel to discuss the WHO MERS-CoV investigation protocols. We have a great list of speakers. First one, being no stranger to everyone, I'm sure, is Dr. Maria van Kerkhove, Director of EPP Department at WHO. We have Dr. Sophie van Dobschwitz, Technical Officer at WHO. Next, we'll have Dr. Anna Funk from University of Calgary, Canada, followed by Dr. El Mubashar, One Health expert and member of OHH LEP. We have Dr. Azuddin Ahmad Okmi from PHA, KSA. And finally, Dr. Abdullah Al Sayafi from WHO. And our moderator today is Sophie van Dobschwitz. Next, onto some housekeeping items. This webinar is being live streamed on the EPI-WIN YouTube channel. The webinar is being recorded, and afterwards, the recording will be available from our website. The address will appear in the chat. Interpretation, okay. We invite you all to post your name, location, and organization in the chat box, and we would love to hear where you're joining us from. Please add any questions you may have to the Q&A box and not in the chat, so that we can more easily keep track of them. So without further ado, I will hand over the floor to Sophie van Dobschwitz for the welcome to this EPI-WIN webinar. The floor is yours, Sophie.
Hello, and thank you very much. Welcome everyone to this webinar. We are very glad to be seeing you here. I'm just checking because I think Maria van Kerkhove should be the first speaker if she's here. If not, can you just let me know? I can't see her in the panelists. Not here yet? Okay. So she might join and close the meeting instead. Yeah, as I said, I welcome you all very, very much. We have updated our MERS-CoV protocols for investigations and studies that are meant to be used by both countries that are affected by MERS-CoV because they're reporting human cases, and also by countries who have MERS-CoV circulation in their camel population. So there are different protocols, and we will dive deeper into familiarizing you with them and how they could be used in your country's context. I'm just going to check because we have, before my presentation, we're going to have a quick Slido intervention, correct? So I'm handing back over to Sophia, and then I'll give you a little introductory presentation myself. Do we have Slido now, or should I present first? I mean, I don't mind. I cannot hear you, Supriya.
Oh, my apologies. So I'm going to share my screen with the Slido. So please join the Slido and at slido.com, number 3631485. And please let us know your feedback. Oh, great. Some people have heard about it. For many, this is the first time I'm hearing about it, which is great because they learn about it. Fantastic. So, Sophie, in the interest of time, perhaps we can move on, but I will leave the Slido open so that, and I'll put the link also on the chat, so that they can continue to continue to respond to it.
Thank you, Supriya. Great. So I will start sharing my slides. And indeed, this
Yes, I
webinar
will.
is addressed to everyone. If it's the first time you're hearing about it, we're very glad to share more information so you can learn about it. If you heard about it, so these are updated protocols, it will still be of interest to you. And if you've implemented them, that's even better. And please share your stories, or feel free to share your stories in the chat. And just to remind you that questions should please be submitted in the Q&A. And we will answer some of them live during the webinar. So I'm just gonna pull up my slides.
Sophie,
Yes.
sorry to interrupt you. It's Maria, and I'm joining very late. Can I just say a very quick hello so that
Sure.
I don't have to interrupt you at the end?
Go ahead.
Is that okay? So thank you so much, Sophie and team and Supriya and Echo and everyone involved in this. I'm really thrilled that you guys are having this EPI webinar today. Really thrilled at the work that's been ongoing with regards to MERS coronavirus, a coronavirus that was around before COVID. And many people have been working on understanding its threat since 2012. And over the last 12, 14 years now of actually looking at what this virus poses in terms of an epidemic and a pandemic risk. It's a respiratory pathogen. It's a zoonotic pathogen. It's one of these viruses that we at WHO work together across the quadripartite, work with our member states, work with many partners around the world to demonstrate the need for using a One Health approach to understand the public health impact. So the protocols that you are discussing today are a labor of love. These protocols have been in development for 10, 15 years, even longer than that. They actually started out with the H5N1 protocols, which were meant to be supportive of our member states and working across different sectors to understand zoonotic spillover and amplification. They were first developed for H5N1. They've been adapted for different types of avian influenza, for MERS, for Zika, for COVID, for Mpox now. And now we're back to updating all of these based on all of the information, all of the lessons learned of utilizing these types of protocols And I'm really thrilled. So, Sophie, I'll hand it back to you, but I just wanted to say a congratulations to you, to Abdullah, to the teams, to everybody involved in working on these. We hope that these protocols are helpful in countries. They have been used. I already know they've been helpful. Dr. Mubashir, I see you online. Dr. Ezdin, I see you online here. I know these protocols have been helpful already, but we hope that they're used even more. And we hope that they can be utilized across many different types of pathogens and really show the added benefit of teams working together, multidisciplinary teams, addressing clear objectives and really trying to understand how important it is to work across the different sectors to really understand these public health risks. So thank you very much. Thanks to all the work that everyone has done on MERS coronavirus, which has been instrumental in our fight against COVID. But it's also beneficial and it's useful to be able to fight any threats that we face. So I pass it back to you and thank you very much. Good luck for the rest of the webinar, and I'm very sorry that I was late.
Thank you, Maria. So that was sitting much better now at the beginning than at the end. I'm really grateful you made it, even if late, no worries. Let me pull up my slides again. So I just want to give you a very, very brief introduction where this all sits with WHO's frameworks and agreements. So all of you will be familiar with the international health regulations, which are a legal agreement that was actually adopted by all 194 WHO member states, and that puts in place regulations concerning the prevention of international disease spread. Another important document that is more recent is the preparedness and resilience for emerging threats. And we have the module 1 already available online. I'm sharing the link here with you, which is the planning for respiratory pathogen pandemics. And then you will be familiar with the HEPA framework, the Strengthening Health Emergency Prevention, Preparedness, Response, and Resilience framework that came together after reviewing some 300+ recommendations from COVID-19 and other recent major emergencies, the lessons learned, and really trying to help countries focus on the most important investments. It has 5 main areas. One of them is collaborative surveillance, and this is where we are sitting with our MERS investigation and study protocols. Under collaborative surveillance, we have what we call the MOSAIC framework, another important framework when it comes to respiratory pathogen surveillance. And the MOSAIC analogy is really to look at the different surveillance systems and studies and how they can fit together like tiles in a mosaic to obtain the full picture of what is going on in your country in terms of respiratory pathogen circulation. And you can see these, we color the tiles differently. On the right-hand side, you have the investigations and studies. And this is really where we come in with our Unity study protocols that Maria mentioned, and where the MERS-CoV protocols are part. So the Unity study protocols are not a new concept. We used to have MERS-CoV investigation tools for a long time, and also for influenza. These were then mobilized when SARS-CoV-2 first emerged to come up with COVID-19 relevant template protocols. And this is when the name Unity Studies was branded. And I'll get to that in my next slide. In addition, we have respiratory pathogen template protocols that look at disease X of respiratory transmission. Because we realized that some of the specifics are important for different pathogens, but other investigations might be broader, especially if you don't know in the beginning with which pathogen you're dealing with. And so we are now at the 2.0 Unity Studies version. The idea is, and this is why we are using the key as an insignia, that we have 3 keys, the key questions that we want to ask and have answered by data, the key generic protocols to use, and the key sites that will employ these studies. And it's important, if you look at the continuum of before, at the beginning, during, and after outbreaks or epidemics, really these studies can be used in any of these periods. And it's important that you look at the questions you want to answer and which study actually helps you answering the questions. And the next speaker, Dr. Anna Funk, will get more into this detail. This was published recently. So this is some results summarized from the COVID-19 Unity Study protocols. You see the colors on the map, and these are 103 member states. That's about 53% of all member states of WHO who have at least started to implement and at least one of these investigations. And the nice thing is that when different countries use a standardized approach and use the same protocols, the results can actually be pooled together and analysis can be undertaken also at regional and global levels, which of course helps us making informed and data-driven decisions about prevention and control of these pathogens. So I'm stopping here. You can feel free to screen the QR code, which takes you to our landing page where the first 5 of the 6 protocols are published. The 6th one's coming soon, and I would like to thank here not only our excellent speakers that have agreed to share their knowledge today, but also many other experts who helped us reviewing the protocols. We looked at recent epidemiology and virology of MERS-CoV and updated specific parts. And of course, we also looked at the lessons learned from COVID-19 and how these were relevant to MERS-CoV investigations and studies as well. So with this, I would like to hand over to the next speaker, which is Dr. Anna Funk. She's the WHO consultant and a fellow of the University of Calgary. And she was really instrumental in reviewing and updating the MERS-CoV protocols and getting them into the excellent shape that they are today. So over to you, Anna.
Hi, sorry, 1 second. Can you see my slides?
Yes, we can.
Great. Okay, so today I'm going to be taking you through choosing which of the protocols in this series you might want to use as your investigation. I'm going to take you through a little bit of what each of these protocols looks like in terms of their structure. I'm going to talk about adapting the study protocols, using them as templates, and then adapting them for your local settings and varying MERS-CoV contexts. And then finally, I'll finish up with other considerations for their use. I'm going to start off with this case study, and I'll be referring back to this throughout the presentation while we talk about examples as well of adapting. So yesterday, a 50-year-old woman with severe respiratory illness was admitted to the hospital that we work at. Testing has just, so November 5th, come back positive for MERS-CoV. Appropriate infection prevention and control, or IPC measures, are immediately implemented as per standard procedure. Myself, a clinician, and you, another clinician, as well as an IPC specialist and an epidemiologist, want to use this opportunity to better understand risk factors for transmission of MERS-CoV in healthcare settings. And we are in luck because the WHO has just published this series of MERS-CoV protocols. So this diagram you'll find actually on the landing page. It's one of the first figures that you see when you go to the landing page for these protocols on the WHO website. And it's also present as the last page in our general how to use these protocols document, which is there as well. And what you're going to see when you look at this is that depending on the type of MERS case you've identified, so primary or non-primary, and the setting in which it's identified, so for example, in a healthcare facility or in the community, you'll see that there are different investigations in this series that might be recommended to look into doing for your context. So we have 5 main investigations. One is a first few cases and contacts investigation. We have a case control study. There's also investigation number 3, we call it, which is a cohort study for health and care workers. Investigation 4 is surface sampling of MERS-CoV in healthcare settings. And then investigation 5
is when you're in a country or region with high dromedary camel density, and you'd like to do a cross-sectional study of MERS-CoV in populations who are occupationally exposed. So for our case study, if I was looking at this, I would immediately gravitate towards, I don't know if it's a primary or non-primary case at the moment, but I see that in either case, I'm recommended to potentially look into this investigation number 3, which is the cohort study in health and care workers. So then I would go back to the landing page and open that up. And early on in the protocol, and you'll find the same structure across all of the protocols in this series, you'll see this protocol summary. This is giving us key aspects of the protocol that we're about to dig into. And we can also use that right now to check, is this the right protocol for our case study? And I see immediately that health and care workers in a healthcare setting. So that looks good. Patient with laboratory confirmed MERS-CoV infection. One of the potential outputs is risk factors for infection, which is what me and my colleagues were interested in looking into in this case study, with lots of other nice outputs. And then maybe I'm thinking about feasibility at this very early stage, and I see that I'll be collecting questionnaires, serum samples, and respiratory specimens. And I know that I've done some investigations like that in this hypothetical situation, and I think that's going to be feasible in my setting. So I'm going to keep digging into this protocol now. And how this protocol is set up is really for use as a template. So we hope that they're going to be useful, where you can sort of copy and paste text, screenshot out elements. If you have a fancy PDF editor, you might be able to just go in and add and remove sections and adapt the language for your specific context. And throughout the protocol, sort of to that effect, throughout the protocol, you'll find these green boxes, which are implementation tips. Sometimes they give extra information on adapting the protocol to your specific context. They can also sometimes give feasibility information or further information on specific topics. So right off the bat, if I'm going to be adapting this as a template and maybe trying to do a quick turnaround for an ethical review board submission, because I already have this MERS case in my hospital, I would just maybe adapt the language. Of course, in the protocol, it's a guidance. So we're saying investigators should create, for example, a detailed map of the facility. And we would encourage you to change that language to, we have created a detailed map of the facility. So this is sort of common sense. And then you would include that map of the facility. So changing the language throughout to reflect an operational protocol rather than the guidance template, which it currently is. Of course, adjust it for your specific context, whether that be regional or your specific MERS-CoV outbreak or cluster, and removing any sections that might be irrelevant for you if you decide not to do one of the secondary objectives, for example, and adding any further sections that might be required by your ethical review board or further methods of interest to you. So here I'm going to go through the general sections you're going to find in each of the protocols in this series with some tips, and this will be shared, all of these presentations will be shared afterwards, so I'm not going to go through this in such detail. But at the beginning, you'll find the scientific background and rationale section, especially if you're using this as a template in a few years from now. Definitely check if it's up to date. Add in some information potentially on your current situation, regional highlights of MERS-CoV. In the methods section, you're going to find lots of detailed flowcharts, tables for laboratory specimen collection, ethical consideration details. So you would want to change all of that language to reflect your actual setting, the number of people you expect to include in the study, the actual laboratory test you'll be using rather than the sort of guidance on what's out there, which we currently have. And then there's a statistical analysis section, which contains guidance. We suggest you use your finalized study methods then to create a detailed statistical analysis plan, and we hope that this section is helpful for that. We highly recommend you include a trained statistician or epidemiologist, and ideally prior to starting the study, so from the very beginning steps. Section 4 of each of the protocols is dissemination of results, giving you prompts and ideas to create your own dissemination plan. Section 5 is study team composition, and here important to think about, based on your final study plan, who else is needed on my team. including various collaborators from the earliest stages. And this section has a nice table in it where you can sort of plan out who's responsible for what. And then in the annexes, Annex 2, Annex 1 is sort of extra information, and Annex 2 is questionnaires. These are usually very lengthy. We don't want them to deter people from using them. They are meant to give a really exhaustive overview of all the questions we could think of that might be interesting in these investigations. So we highly encourage you to remove questions if they're not feasible or appropriate in your setting, potentially add some if you've added a further secondary objective. And then sometimes in those questionnaires, you'll find a light blue text, which asks the investigator who's using the template to specify for your context further response and answer options. Question and response options. Okay, so moving back to my case study, now we're going to go through a few examples of things you'll see in the protocols and how we might adapt that for our case study using this protocol as a template. So in the methods section, if I'm looking through, I have this MERS-CoV case in my hospital, and I'd really like to get the study started as soon as possible. So we actually have a pre-ethical approval at my hospital because we have all these WHO protocols. So we submitted them for sort of a rapid ethics review when we have these situations happening, and they've already seen these templates. So that really facilitates a quick turnover. And I see that there's this graphic. It's showing me that on a certain day, I have my MERS-CoV positive patient identified in the healthcare facility. I'm using the following days to prepare for my study, and then it seems to show me the timing based on date following study start, when I'm doing certain questionnaires, when I'm doing certain specimen sampling. And so what I might start to do using this as a template for my case study is I might just use it as my own tool for planning and include the dates that I know are specific to my context. So my MERS-CoV patient came in yesterday, so November 4th. I'm using the next just day or so to quickly turn over this template as an actual protocol for my study. And I hope that if I can get ethical review board clearance, I can even potentially start to enroll tomorrow. This is probably not feasible in all settings, but just an example of what can happen, especially if you have these protocols pre-approved, sort of. And then what happens here in this purple box is that it gives an idea of if I have a healthcare worker contact testing positive, this might lead to a further study branch. And so for my own planning, I sort of, and thinking about my timing and human resources that I have for this study, if I, did have one testing positive around November 13th, I would have an extra study branch. Okay, so this has been useful for my planning. And now I would actually like to submit this diagram in my protocol to my ethical review board. They're going to like seeing those specific details. So I'm going to, of course, remove that hypothetical part because it's hypothetical and it doesn't belong in sort of an actual operational protocol. Great. So now I'm moving on to the laboratory and specimen collection section. And in that section, I'm going to find this table, which includes types of samples, and then again, looks like details on collecting them. It says here we have a serum sample collected at baseline and then a paired serum sample. I seem to be collecting nasopharyngeal and oropharyngeal swabs if I have a healthcare worker contact who experiences symptoms, and then a lower respiratory specimen. But you know what? I find it says it's optional, and I find that this is a really complicated specimen to collect in my setting. And I think this could delay my ethical approval. So even though it's not recommended and it's highly recommended to collect it, I might actually remove this in my specific instance. And then I see that there's this implementation tip, which mentions I should, of course, specify the actual volume of blood I'm going to be collecting and think about outsourcing some testing if it's not available in my hospital. So I'm going to, again, use this as a tool, use it as an image in my own protocol. What I'm going to do is I'm going to delete that lower respiratory specimen. I'm going to change the language to reflect an operational protocol, so removing shoulds and replacing with wills. And then I'm going to specify that I'm going to collect 10 milliliters of blood. I'm going to specify the actual test I'm going to use, which is Euroimmune in this context. And then as I'm looking through this, I realize I don't have a laboratory person on my study. which is going to make it really difficult for me to finish planning out this section. So what I've done is I've added in some of the details, and then this has been a really good reminder that I need to contact my laboratory colleagues, include one of them on here as soon as possible from the earliest stages, and confirm all of these highlighted points with them. Going through all of the methods, I now make it to the questionnaires. So in the questionnaires, this is questionnaire number 3, which is a questionnaire that's going to be given to the health and care workers who are potential contacts of this MERS-CoV infected patient. I see that I'm going to collect sex, okay, age, nationality, but I see that that's free text, which might be a little bit difficult for me in terms of my data cleaning. I don't know if I'm so keen on that. And then I have ethnicity. It says it's optional, and indeed, this is a little bit of a sensitive topic in my setting. I'm probably going to delete that, therefore, and country of residence. And I'm pretty sure that in my hospital, almost everyone, I think everyone has to be a resident of the country to work in my hospital. So I'm going to adapt this a little bit to make it easier for my study team and easier for my data cleaning. So in terms of nationality, I'm not going to really have it all being free text. I'm going to add in our country and an adjacent country because I know almost everyone is of those nationalities in my hospital. And I'm still leaving this other free text option in case there's any international colleagues who are working at our hospital. I've deleted now the ethnicity question because it's not really appropriate in my setting. And country of residence, I've slashed it out. I'm going to talk to my other clinician, so you and other people working on my team, to see if they agree that everyone who works here has to be a resident of the country. I'm not exactly sure about that. Okay, so I hope that's been useful to give you a little bit of information and examples on how you might adapt this protocol for your own use, with the idea of having a quick turnaround as well, potentially, depending on your MERS-CoV cluster outbreak context. Finally, we would like to encourage you to seek external support, whether that be in country, if you're looking to outsource some laboratory investigations that you can't do within your own hospital or community. And of course, please do reach out to WHO to inquire if we can give any support with genomic analysis or other laboratory support, data sharing. So if we know about other studies that are ongoing where data could be pooled, and efforts to that extent, and also for statistical support. We also encourage you to think about linked investigations. So as I mentioned at the beginning, we have 6 investigation documents, 5 which are investigation protocols, and 1 which is a how-to. So in the situation of our case study, we have this health and care worker cohort investigation. And some that might complement that investigation are the case control, where we have that initial MERS-CoV case, the 50-year-old woman. She might be a primary case, and this might be something we could investigate with a case control study, which is also included in this series. And we also have our protocol 4, which is environmental sampling of healthcare setting, of MERS-CoV in healthcare settings. So this is another complementary investigation to this health and care worker cohort investigation. And then again, we really just want to reiterate that we hope that these are useful as templates, as tools where you can copy and paste text, adapt it quickly for your own use. And if you do that, though, we encourage you to just see the copyright details, which are on the second page of each protocol. It just gives you information on how to cite the template if you are copying out the text. And thank you very much for listening.
Thank you so much, dear Anna. And over to our next speaker, who is Dr. Almobashir Farag. He is a One Health expert and member of the One Health High-Level Expert Panel, or OLEP, which advises the quadripartite organizations FAO, UNEP, WHO, and WOA on all questions related to One Health. And he will tell us about a success story, how the One Health approach is important for implementing these kinds of studies. Over to you, Almobashir. Thank you.
Thank you so much, Sophia, and the team for having me here. Can I have the slide? So thank you so much, Maria, and Sophia, and Abdullah. So I will reflect on how the One Health can help in the efficient implementation and effective implementation of this protocol. My presentation, it will be based on my experience, like in the last 10 years on doing investigation in relation to MERS coronavirus, as well as the respiratory infection and the zoonotic disease. Can you have the second slide? Yeah, so this is the outline. So mainly it will be the focus, what is the secret of success? Because sometimes you have the protocols and the framework as guideline, but how you can implement this when it came to the reality. So my presentation to be answering this question. So why we need the One Health, and then about the efficient and effective implementation of this slide. Can I have the second slide, please? Yeah, so all of you, when they will be putting in this situation, this is this photo is like it's so special to me, and this is exactly when reported the first case in Qatar, and then they asked me to go to the field and do the investigation. This is one of the famous camel. This is the first camel when we did the investigation, and then MERS coronavirus isolated from this camel. You can see from this slide, myself and the team, we have a veterinary doctor as well as the camel workers. He is part of this, and then we did the investigation. During that time, unfortunately, we don't have guidance. We don't have any framework. We don't have any protocol. This is the new emerging virus. What we have is a generic outbreak investigation. So this is the beauty when Anna, she mentioned you have a flexible, you have a reference. During that time, we remember you can go easily, you have a reference document, you have a guidance, it will help you a lot. Listen to me, and I mean, like in this, I'm worried what kind of things I can follow. What is the guidance for this? Yes, I'm helping the veterinary team, but really in my mind during that time, I remember we don't have guidance, we don't have, as I mentioned. So can I have the second slide? So this is a situation in regard to all emerging infectious disease. You will be put it, you will be putting in like such situation. In the middle, when we have the primary cases or the secondary cases, you can call them. And this is exactly the setting of my photo. And during that time, if you implement the right protocol, if you have this, the science, this it will be the area or on the moment where you can guide the whole investigation, where you can guide the future intervention. So it is critical. It is so crucial to have guidance and to have protocol to follow. The second slide, please. Yeah, so it is the same slide, and this is the complexity of, determinant of the emergence of the infectious disease. So it is the same situation. You have something, you need to have the guidance to do the comprehensive, complemented investigation. So it has to be at the human element interface. It can be in the hospital, and it can be at the, the house level. It can be at the, the healthcare. So the unity study for MERS coronavirus, it will help you a lot to do integrated. This is the beauty of those, the set of the protocol, because integrated, as mentioned by Anna, you can do this at hospital level, at human interface. You can do even multi-method. So you can do case control studies, you can do cohort, you can do service, studies can be integrated with the surveillance. So there's a lot of kind of benefit it can be out of this. Can I have the second slide, please? Yeah, so this is the One Health. To do investigation at the human element interface, One Health to be one of the major tools, and it will be one of the foundation of the success. So One Health, it will help you to have the understanding about the spillover risk factors, what has the determinants. In addition to this, you can have the initial understanding concerning the risk factor and the mode of transmission. This is for sure, it will help you how to have the case definition at human-animal interface. So this is about, I mean, One Health. You cannot go for such kind of investigation without the One Health team. So the One Health, the One Health team, the One Health in terms of teams, the One Health in terms of samples, the One Health in terms of data, the One Health in terms of the timing, the One Health. So you cannot go without One Health. It is so crucial. So here's just the definition of the olive team on One Health. That mainly One Health, you will do the investigation, taking information and sample from human, taking information and sample from environment, taking information and sample also from different kind of animals. Can I have the second slide, please? Yeah, so Sophie and Anna, they talk about the rationale. For me, and from my experience, the bottom line is having guidance. When they reported cases, during that time, it will be, there's stress, there's a lot of uncertainties, what to do, with what kind, with whom, the team. So here's a rationale having such kind of protocols. It will help you to be well guided. It will, because sometimes you need to prioritize your effort, your resources. Here, the protocol, it will help you in like having, I mean, to be more strategic, dealing with such kind of outbreaks, and also such kind of protocols. It will give some unity. For example, the outbreaks or pandemic it will start in one country, and it will spread. Those protocols, it will unify. So whatever it will be implemented in country X, it will be the same implemented in country Z, and then people they can compare later on. It will ease sharing of information. It will help the quadripartite to have the strategic information in a well-organized way of things. Countries also they can share their experience. So there's a lot of benefit out of having such kind of protocol. So it will help the world to understand the pathogens, and also it will help the countries in like very fast to understand the origin and the risk factors and the mode of transmission. So I hope countries they buy-in to this protocol. It will be in a systematic way, and it will be facilitated. So you will have the slide, and then you can have also your future experience with this slide. Can I have the second slide, please? So this is prevention of the zoonotic disease at the spillover, or having this primary kind of prevention. For sure, if the countries they manage to implement those protocols, in the end, it will help them how to cross the chain at the primary level. And this is one of the strategic importance of having this. So you can cross the chain of infection at the human-animal interface. You can cross the chain of infection at the hospital level, because using this, you will have the strategic information and you will have the evidence about the interventions and how to control the outbreak or pandemics. Can you have the second slide, please? Yeah, so this is so crucial. So the implementation of this protocol, you need to have a team, and the team, it has to be multidisciplinary. I remember part of the team we have laboratory, part of the team we have even the workers, as I mentioned, they are so crucial. So this is the team, because without the workers, the buy-in, who will give you the permission to enter the farm? Who will help you, holding animals? Who will give you the information? So it has to be a multidisciplinary team. This is so crucial. And then you have to have resources in terms of personnel, resources in terms of logistics, resources in terms of finance, resources in terms of labs. This is so crucial for you to implement. And then you need to have the governance. I mean, this is part of the quadripartite at the country level or the local level. This is so crucial. It will help a lot having permissions. It will help a lot, I mean, like in providing the resources. And then the term of reference and the division of labor. This is crucial. Before implementing this, you need to have what is the role and responsibility of the animal team? What is the role and responsibility of the human team? What is the link between different teams? I mean, like who will go first? Those kind of things, it will give the reality and like the division of labor and the responsibility. This is my responsibilities. This is your responsibilities. This is how we are going to do this work together. The samples, it will go to which lab? Is it outside or inside? This is one of the preparedness things you need to do in advance because it will help you to maximize the outcome of this protocol. And then listen to me. Sometimes you need to have a global partnership in advance. For example, whenever as part of this, we need to go for this country lab. They need to be about the shipment, what the condition of the shipment, who will pay the cost. So this is because sometimes your sample, it will be the precious one. Your sample, it might be having the answer to the origin of the outbreaks. But without in advance agreement and partnership with those kind of labs, the world, they will miss the opportunity. Then you have to have like agreement between the quadripartite at your country, the agreement, because sometimes there is legal issues between sharing of samples and the information, who the command of the team. This is so crucial. I call this a capital. Without this it will be just additional paper, like the protocols we have at different level. So, and then it has to be endorsed. The endorsement of this protocol is so crucial. The Minister of Health, they need to endorse a protocol. On the quadripartite and even at the academia, they need to endorse the protocols. And after the endorsement, this is as part of the preparedness at your country. And then in advance, ethical approval and the ICOC from the IRP and the ICOC committee, from our experience, this is so crucial because they will have a lot of discussion and then they will give you this approval, and then you can use the approval to do, I mean, like things after sharing of samples, sharing of data. And this is fortunately, it is, I mean, like right now, most of the ethical board in countries, they agree with this. And from the quadripartite and WHO, they can help countries if they have the ethical approval from their end. They can provide this because the ethical committees, they will ask you, is the WHO or whatever, they have ethical approval? I can tell yes, and then this is yes. So in terms of support, the logistic is so crucial for this protocol to be implemented. The logistic here, I mean, like transportation and then whatever, political support, use of technology. From my experience, use of technology, there is a lot of apps, there is a lot of, I mean, starting from SPSS machines, it can help you to have this because in the end, it will raise the quality of the implementation. The accessibility, sometimes you have everything. You have good team, you have the laboratory that are ready, but farm owners, for example, they will not allow you to enter their farm. So the accessibility here, you need good relation. You need the political support, and I mean, like you need the buy-in from the community. This is why the community, they are so crucial in implementing such kind of thing. And the data sharing between sectors, because sometimes you have part of the coin, but you cannot complement this because the other sectors, they will not agree to, I mean, like to share their data. This is so crucial for this integrated kind of protocols work. And then the One Health pocket, because sometimes the problem will be at what expense, I mean, like who will take care of cost of the lab, who will take care of the cost of the shipment, and then the bureaucracy of this at different department, and we have budget, and this is the budget is for health, human health, our budget is for animal health. Those kind of things, it will be at the governmental level. So this is why the quadripartite as umbrella, it will help this, and in terms of management, it will help you if you solve and have this in advance. The laboratory, this is, without question. And then the final
Dr.
part is
Mubashir, sorry for
yeah.
interrupting, but we really need to wrap up because we have one more speaker and only 10 minutes left. So if you can wrap up quickly, thank you.
Yeah, I will. So what I mentioned is like it will help you really from our 10-year experience is like to implement this, and it will increase the efficiency. Finally, please go for piloting. You need to go for piloting, training, and don't forget to integrate this as part of the rapid response team. And if you have a field epidemiology training program, customize, adapt the protocol to your existing field epidemiology and the rapid response team. Can I have the second slide? Yeah, so whenever you hear you have outbreak, you have as part of the preparedness this protocol. The last slide, please. Yeah, so you will be happy like me, and the camera also will be happy when you implement the protocol. Thank you so much.
Thank you very much, Dr. Mubashir. Are we having another Slido or?
No, I'm done.
Yeah, no, I know I'm asking the organization team, or should we continue with the last presentation? Can you just let me know, please?
Oh, my apologies. Yes, we are having another Slido. So just if you can see my screen. Can you see my screen?
Not the Slido yet. Okay, this is
the no, this is the next one. So the same link, slido.com, hashtag 3631485. Please, will you use the MERS Unity study protocols in your work? I will now stop sharing in the interest of time on the screen, but the Slido is open. So please go to slido.com, hashtag 3631485, and continue to share your response to this. Over to you, Sophie.
Thank you so much. And this just helps us understanding how many of you would be interested in actually applying these protocols if, relevant to your work and your setting. So thank you very much for answering this. I will quickly hand over to our last speaker of today before we're answering a couple of questions live. Can I please ask Dr. Ezzuddin Ahmad Ogmi from the Public Health Authority in the Kingdom of Saudi Arabia to tell us how Saudi Arabia adapted the Unity Study questionnaires to their local context. Over to you, Dr. Ezzuddin. Thank you.
Yes, thank you, Sophie, and thank you all.
Yeah, can you please put the slides in presentation mode?
Yeah.
We don't see them yet in presentation mode. Thank you.
Just wait a minute. Yes, for attendance, and my presentation will be about adapting Unity Study questionnaire to local context. An example from Saudi Arabia. With you is Dr. Azzuddin, is Director of Respiratory Infection Surveillance and Prevention at Public Health Authority. My objective is introduction, how KSA adapted this questionnaire, and how the KSA is planning to move forward to increase the awareness about this study protocol. So, introduction, you know that data is very important for the surveillance, for epidemiological feature, and also for understand the geographical existence of the circulating, MERS in human and camel. So, what is the factor could influence the response to the questionnaire? In Saudi Arabia, we have a lot of factors that affect the questionnaire, and you know, this questionnaire is tended to be a global questionnaire, but when we was like expecting there is some difference in the question and cannot be like applied to the local area here in Saudi Arabia. The problem or the reason was the cultural difference, as we know, and also because the people are more familiar with the MERS and also the health care access. We will see how after we collect the data, how this is what was the response of the participant, and also the regulatory environment, because in Saudi Arabia there is have different regulation, like not to having a farm and or not to having animal, sheep and cow in the house. And also the religious belief, we know that some people believing that the camel milk have benefit for medication, and this is for I mean as a remedy. So this is important to precise the question. And finally, the personal experience. You know, most of participants there knowing, and some of them was exposed to such disease. Okay, so what was the type of questionnaire? We have a 5 questionnaire, almost have a similar content: camel owner, camel farm worker, camel market worker, and a better worker and a better owner. So the purpose of the study, we get in the field. The purpose of the study was pretest the questionnaire to enhance the reliability and validity. We choose a Ta'if city because a Ta'if is very known of the camel farm and also camel market. And also we choose the methodology. We're having like first what is called phase validity. After that, we making the questionnaire, but we're making a convenient sample in the field. Face-to-face interviewing was conducted. Before that, we trained that the interviewer to how can have the exact translation, because the questionnaire was in English. So what was the result and what was the issue? In this table, we will present the issue and what was the question or suggested question we think this is suitable for a culture in Saudi Arabia. For example, question: do you hold other job aside from working? Because some of them are working in the health sector, and Saudi Arabia can work in the health sector and also working on the farm. So this is maybe an issue and maybe sensitive. Also, do you have eat raw camel milk? This is also is not common. In Saudi Arabia, they eat raw liver and not the meat exactly. And some having a religious rule or problem that is not allowed. So we suggest like to explain such as liver. Other question was, do you have any livestock kept around home? this is actually either law of Saudi Arabia allowed to having livestock in the home, since that the Rift Valley fever that was not allowed, even if they were answering, with suggesting to also have to have them free. Where are you like kept this livestock? The other question, in the last 6 months, did you have any with the, let's say, this was the only problem also was in the home. This is not usual and it's sensitive. Some of, as I say, some of them was avoiding them. So we like either keep it both in the answer, farm and home, or like keep it farm or make it in other place. Okay. Also, another sensitive question based on the belief that, do you believe that camel or camel product have medicine or therapeutic properties? This question was very highly sensitive because, as you know, that in our culture as a Muslim, that we believe that is therapeutic. So if you said no, this will be a sensitive, and the people will not say actually no because they believe it's have a treatment ability. So we like suggest to change it to which camel product do you use, believing that the camel or their product have medicinal or therapeutic properties. Also, there was an issue in remembering. It's like where do you hospitalize during course of the illness? We like suggesting like to having in the last 6 months to make it more precise. The last one was when we said like, have you attended recent mass gathering? Something was not added, like cautions. It's very, very famous in Saudi Arabia, and also this term religious pilgrims is not familiar in Saudi Arabia. We say that Hajj and Umrah, and this can be like limited just to the local context. So this is what the problem, as we expected, because of the difference in the belief and also in the culture. Finally, how can we make the great benefit from this study or from this protocol is important, like in organizing workshop, training session about the importance of using this study protocol, also collaborating with other stakeholders, let's say in the universities, in the schools, and also in the health sector to enhance and using and disseminate this information. Also in participation, we can like have offering this for the people who are in the board or in the fellowship that can like using this protocol for publishing a study for it will be like a graduation project, and this will help them, and also continuous engagement for this protocol and building research capacity. Finally, also showcasing success story, highlighting successful collaboration or outcome from the study will encourage further participants and demonstrate the value of the unity study for public health, as we doing right now in this presentation. Thank you, and I'm happy to hear your question and comment.
Thank you very much, Dr. Ezzuddin. And this is really an important message that, of course, WHO and partners and experts contributing, we're trying to put out guidance that is as applicable to any country setting as possible. But you will appreciate that it's very important to field test both questionnaires and protocols in order to make sure that it really fits your context. And we expect some adaptations will need to happen in order for you to increase uptake at the field level and enhance the information that you get out from these studies. So we are at the end of the webinar in terms of speakers. I would like to hand over to my colleague, Dr. Abdullah Al-Sayafi, who works with me in the WHO headquarters MERS team, to help us answering some of the questions that you posted. Thank you so much for all the questions and the Q&A section. We tried to answer as many as we could already in writing, but there's some we wanted to take up here for the audience. Over to you, Abdullah.
Thank you, Sophie. Good day, our colleagues and partners. So for saving times, I would give 2 or 3 questions for immediately to the speakers. So the first question would be directed to the lead of the MERS in HQWHO, Dr. Sophie van der Schot. What is the headquarter plan to roll out this protocol in country? What's the criteria to provide headquarter support for implementations?
Thank you. And of course, we are very happy to support, and there's no limit to supporting technically. If you have any questions on these protocols and how to adapt them best to your context, we're always happy to answer these questions and provide our technical knowledge and technical support. When it comes to funding, of course, there the situation looks a little bit more difficult and different. But we do occasionally have interested donors who like to increase our knowledge from these studies in the field and who are open to funding these studies. Then again, it depends on the context, if these are important knowledge gaps that need to be filled, if these knowledge gaps have already been highlighted in international forums, and so on. But of course, again, inviting you to reach out to us in case you have any questions or any suggestions for field implementation.
Thank you, Dr. Sophie. And the second question will be directed to Dr. Anna Fang. So we have a question from one of the audience saying, when submitting the protocol for pre-ethical approval, are you submitting the entire protocol or it is dummy protocols tailored to a specific health facility? Considering that patient may present at any hospital and this is being done pre-epidemic, do you submit the protocol for approval without specifying the investigation site? Over to you, Anna.
Hi, thanks. That's a really good question. The idea of getting pre-ethical approval would be, of course, really excellent for having that quick turnaround with starting these investigations. And sometimes, of course, these are very time sensitive to start, following healthcare worker contacts, for example. In some settings, it might not be possible to get any sort of pre-ethical approval. Obviously, it would really depend on each specific ethical review board. But definitely, one option could be taking the protocol as a template to the ethical review board for sort of an off-session review where you go through sections of the protocol that would be more sensitive or problematic and sort of, have their eyes on it with the knowledge that you might be asking for a really quick turnaround in the future, which, you might get information from them if that's even possible. Or, I like the idea actually that you mentioned, Abdullah, from the question about potentially if you're really focused on a health facility or maybe multiple health facilities in one health system, having a sort of dummy protocol where you can actually further specify some elements, this would probably greatly facilitate that pre-ethical approval and rapid turnaround.
Thank you, Dr. Anna. It was very helpful answers. And the last questions, and our apology for our audience because we tried to answer as much as possible within the webinars live. And the remaining question, which we couldn't answer either live or written, we will be collected and answered later on by each speakers and will be shared with you as a Q&A leaflet. So the second question would be shared with, it would be directed to Dr. Anna and Dr. Sophie. One of the audience saying, could you discuss to what degree using this protocol will enable comparing and interpreting results across country? Will they allow quantitative statistical comparison, qualitative? What considerations are needed when looking at the results of the unity study from region, global level? Maybe we begin with Anna and then we direct it to Sophie.
Thanks, Abdullah. So this is a really good point. I didn't mention that in my presentation, but of course, One of the main objectives of publishing these protocols and updating them was to give these templates to people in varying countries and settings to use this as a template and have a tool for them. At the same time, it's a global effort to ensure comparability of findings, because MERS-CoV is still an emerging infectious disease for which, for some aspects specifically, we still have very little information. And then, of course, you have some situations like with case control studies where we struggle to have enough power to determine risk factors for infection and things like that. So definitely one of the main objectives of these protocols is to ensure comparability. I think overall, the use of these protocols will increase comparability across findings, and the level to which that will happen will, of course, depend on which aspects of the protocols are implemented. It will always depend on how many people are using certain tests versus others, and then aspects, the way in which results are statistically analyzed. But again, with all the length of guidance we've given in the documents, we hope that overall, we will be moving towards more and more comparable findings across regions. And Sophie, on to you.
Thank you, Anna. Indeed, I completely agree. And just to close this, and this will be my last remark before handing back to Supriya for official closure. So, of course, I mentioned earlier that these kind of studies are also being implemented in order to shed light on outstanding research questions and to understand, should we have a MERS outbreak in a country, and especially maybe in a country that wasn't prior affected. And so this is a new development. Then, of course, the information gathered at country level is super important for the regional and global levels in order to understand the epidemiological parameters and characteristics of such an outbreak, so we can target our preparedness and response measures, and we can also issue appropriate guidance to other countries that might be at risk, how to prepare and how to prevent an outbreak on their end. So don't think that you have to deal with an outbreak or an epidemic in your country on your own. Of course, WHO is there to support, and of course, the information that you generate also through these studies is very, very valuable, extremely valuable, in order to address what is a global issue. MERS-CoV is really a global issue, although currently most of the human cases are reported from the Middle East, but any country is at risk because travelers could take the disease to their home country or to another country in less than 24 hours. So thank you very much again for participating in this webinar, for your inputs, for sharing your thoughts, for asking excellent questions. And back to you, Supriya.
Thank you very much, Sophie. And as we close, first of all, I'd like to thank all the participants for such active participation. I just wanted to quickly show to you the results of your poll, in case you're wondering. I'll also now share with you the upcoming EPI-WIN webinar, which is tomorrow. Can you see it on my screen?
Not yet, Supriya. Oh, it's coming.
Okay, here it is. So thank you very much to each and every one of the panelists for very engaging presentations. I think many more people are now aware of the Unity studies and will be interested in knowing more. So that's great, at least judging from the questions on the chat. I'd also like to thank everyone who's worked in the background, my colleagues, Sophia, who introduced the webinar, my colleagues from Project ECHO, Kanika from the Project ECHO team, Constance, who's been working in the background to the run-off show, and last but not least, everyone, Sophie and Abdullah, for putting this together. It hasn't been easy, because we had to reschedule and there's been issues, but I'm so glad that everyone came together in this webinar, and thank you very much. I hope to see you tomorrow for the webinar on Health Meets Peace. It's the first webinar that we're having on the Global Health and Peace Initiative of WHO. So please join us tomorrow to learn more. And there are more webinars coming up next week. Hope to see you soon. Bye.